Welcome, everyone. Welcome to the Ontario NEIHR Waakabeness Institute monthly Indigenous Health webinar. It's great to have everyone here. Thank you for coming. I know more people are going to pour in, so we'll just let people come in, and we will invite our knowledge keeper and elder Clayton Shirt to do a spiritual opening, and then I'll get started with the introductions. My name is Etsy Stewart, also known as Suzanne Stewart. I'm from the Yellowknives Dene First Nation in the Northwest Territories, and I'm the director of the Waakabeness Institute for Indigenous Health Research. And along with a bunch of other great people, including Carol, I lead the Ontario Network for Environments and Indigenous Health Research, known as the Ontario NEIHR. It's a mouthful. And as part of our work with the network, with the Indigenous Health Research Network, we do monthly webinars, and we invite amazing people from within the network and within their networks to share their work. And it's on those those relationships that we humbly invite Carol Hopkins to be here. And Carol is one of the most eminent people in Indigenous mental health through the decades, and I feel really honored to be here in this circle with you, Carol. And Carol is the Chief Executive Officer of the Thunderbird Partnership Foundation and is from the Lenape Nation. She was appointed as an officer in the Order of Canada in 2018. Woohoo! And in 2019, she received the Honorary Doctorate of Laws from Western University here in Ontario. She spent more than 25 years in the field of First Nations substance use and mental health, and has a master's in social work from here, University of Toronto, and a degree in sacred Indigenous knowledges from Medewin, which is far exceeding anything that anyone could get in a Western-based education system like a PhD or even higher than that. And Carol, throughout her career, has made use of Indigenous knowledges in practice, policy, research, teaching, education, and in facilitating these difficult processes of decolonization specific to epistemic racism. And she has co-chaired national initiatives for best practices in national policy review and development, and her leadership has been engaged within health and mental health for First Nations, provincial, territorial, and federal governments, and has served as several expert advisory committees and task groups. So I'm going to turn it over to Carol to talk about the topic today, which she has graciously agreed to share with us, and that is about a model of care for community-based substance use and intervention. And I'm really excited to hear about this. So, Carol, I'll turn it over to you, Miigwech.
Miigwech, for those great introductions. I am especially grateful for that prayer and the recognition of and inclusion of my family. I'm grateful to be here with you today, and I'm grateful for that opening, working from a spirit-centered approach. It is true; it's difficult to work that way in this virtual environment, but yet we do it, and it is our belief that no matter how we are sharing time and space together, that when we pray together, we're assured that the Great Spirit hears us and will answer us. So thankful for that prayer, and thankful for the work of Waakabeness Bryce Institute and the invitation to share time with you today. We wena bojo no jemen dijna kaz gaye maingan and dodam lane lanape kwe and dow lanape a king and don jaba negabe mede kwe. So I introduced myself in my spirit name, which is Nojem, and my clan is the Wolf Clan. I come from the Lenape Nation, otherwise known as the Delaware people. My father is from the Munsee Delaware First Nation, just outside of London, Ontario, along the Thames River. And then further up the river is the community of the Delaware Nation at Moravian Town, which is where my mother's family line comes from. And this community is also the host to the head office of Thunderbird Partnership Foundation. More importantly, I am a mother of 4 adult children, and I have 10 beautiful grandchildren and 1 great-grandson. Um, I always like to counter that long and bio that is often used to introduce me with, I'm a girl from the res that likes to talk a lot. I'm very passionate about my work. So um, just offer that little chuckle there. I'm going to share my screen and move into the presentation, and hopefully I leave some time for any questions or discussion that might come about. So this is about a model of care for substance use, and it says 24, but it should be 25, still operating on last year's timeline. So there we go. Thunderbird is a national organization that serves First Nations across the country, and we draw our mandate, what we focus on in our day-to-day work, from these 3 frameworks. I'm going to briefly introduce them and say a little bit about them to help you understand some context for this model of care. The first one is called the Honoring Our Strengths, a renewed framework to address substance use amongst First Nations in Canada. This framework was developed through conversation with First Nations across the country. So every province or region, they facilitated their own process, invited who they wanted, conducted their own literature review to look at more deeply the evidence that would help to paint a full picture and tell a story on the priority of needs in that region, in that province of First Nations people. And then we met as a national group to guide and advise those regional processes, and then also to synthesize the results. And that synthesis resulted in this framework. Now, I know the words are very small, but you can go to our website and you can get each of these frameworks, as well as find more work that demonstrates the implementation of these frameworks. So this framework largely focused on substance use. And there are, like I said, many literature reviews, many environmental scans and conversations and engagement with First Nations as well as provincial governments to inform this framework. And first and foremost, this framework wanted to present a continuum of care. So it's not just community-based prevention work and residential treatment services, which is what First Nations are very familiar with. Community-based prevention, residential treatment, live-in treatment centers. But there's much more that we can think about in addressing substance use amongst First Nations people and communities. And so that continuum of care was developed from those conversations, from that literature review. But then we also wanted to understand, what are the levers, what are the things, what are the components that need to be in place, that we need to highlight in order to understand what's going to make the continuum of care work for us as a people. And then we had a conversation with a national working group of elders and Indigenous knowledge holders. And we asked them, what is your best advice? We thought about that conversation as parallel to a literature review. In a literature review, you have certain criteria that you go and you dig in a literature and you find what there is that represents the conversation and the evidence that you're looking for. Parallel to that is that Indigenous knowledge, those knowledge keepers. And there's certain criteria that is used to, in our understanding, to qualify that expertise. And so perhaps it's you have fluency in a First Nations language, or you're recognized by your nation of people as a knowledge keeper, or you have knowledge of the story of creation of your people. which is the foundation of our evidence base as First Nations people. So we gathered those folks from across the country. We had met with them for a few days, and we asked them, our central question was, what best advice can you give us for informing the way we structure our response to the needs of First Nations related to substance use? And they talked, and we listened. And from the conversation came the outer circle, which is kind of like a sage green color, and it's the principles. So they said if you use these principles to guide how you offer services, how you design and develop and offer services, then you're going to be offering services that are relevant to First Nations people. Now, in those principles, many of them you'll be familiar with, but there's one that stands out, and that's spirit-centered. So amongst the evidence base, cognitive behavioral therapy is where you'll find the most evidence for addressing substance use. So cognitive behavioral therapy is a model or an approach to addressing substance use. Lots of evidence on that. However, at the time we were developing this framework, the evidence for cognitive behavioral therapy, it does work for First Nations people, but there's rarely any First Nations Indigenous populations that are represented in that evidence base. So that evidence base is largely based on a white adult male population. So if we're going to apply the evidence base, we want to make sure that it fits a First Nations population. And so in cognitive behavioral therapy, the elders said, well, that's good work. It's going to help us. It has helped us, but it's never going to take us far enough. And the issue is that it doesn't tend to include our worldview. So it doesn't look at us as a whole person, and it doesn't attend to our spirit. It has to attend to the spirit of First Nations individuals, First Nations families, and First Nations communities. So that's at the very center of this model, that it's not just the individual we're thinking about, it's family and community as well. And they can't be separated. That whatever we do for the individual, we should be thinking about what outcome, what difference does that make for the family and for the community. So those are key components that is different in this framework, spirit-centered as well as family and community within the continuum of care, looking at the whole person. There's a chapter on research in this framework, and it says that First Nations people, we had another conversation, again, going across the country, inviting academics and researchers, as well as First Nations service providers in substance use. And the conversation was, where are we at? What are the research priorities? What do we need to understand more about? And is there an interest in matching research questions, processes, and projects and methodologies with Indigenous knowledge and culture? And we got a resounding yes. First Nations people across the country said, yes, we want to do more research to demonstrate how culture makes a difference. We don't want to approach research from the perspective of the deficit-based question, the issues, such as there's a high rate of substance use amongst First Nations people. And what is the answer? Well, we say, well, maybe culture might help that. So let's demonstrate how culture makes a difference. From that research conversation, we did get the resounding yes. There was a lot of interest in demonstrating how culture will make a difference to address substance use. And we wanted to make sure that we were developing a way to measure the difference that culture makes. And so that's the middle framework, the Indigenous Wellness Framework. Out of that 3-year conversation, First Nations people across the country and service providers said that if we are going to create wellness, then we need a definition that is grounded and built from Indigenous knowledge and culture, and not the mixing of cognitive behavioral therapy and emotional intelligence theory and matrix models, all of the different approaches to addressing substance use, we have to work from the foundation of culture first, our own knowledge. And so there were 3 questions. What is a whole and healthy person? What do your teachings, your knowledge, your community stories that have been passed on through generations, what does that knowledge base tell us about who is a whole and healthy person? How would you describe that person? Resoundingly across the country, people said spiritual, emotional, mental, and physical wellness, a balance of those 4 aspects of our being. Again, mirroring what the elders said, a spirit-centered approach. And when we talked about if your nation of people have teachings and cultural-based practices and knowledge about that whole and healthy person, then you must have ways to facilitate that whole and healthy person. And so people talked about their cultural practices across the country. We didn't record recipes for this is how this is how you say a prayer, or this is how you run a sweat lodge, or this is how you run cultural craft sessions, for example. But people talked about their cultural practices and their knowledge, and the populations, the situations where those were employed, how they're still relevant, how they are still alive, how they are still accessible today. And so we documented those cultural practices, and we found that there are about 40 common cultural practices. Now we didn't mix them all together. That would be called pan-Indianism, to say we're gonna, take this from the Coast Salish way of running sweat lodges, and this aspect from Mi'kmaq people, and this aspect for Cree and Dene, and we're gonna mix them all together and standardize a way of doing sweat lodge in treatment centers or in community. That is absolutely not what we did. But we identified sweat lodge is a key practice in addressing substance use. Language, our original sound, is critically important to our worldview. And so we said, our third question, when we employ those cultural practices to address substance use, what should we expect the outcome to be from Indigenous knowledge? What does it look like from our cultural-based practices? What are those practices? What are those outcomes of those practices? And so again, across the country, we heard the stories, we brought people together to listen to each other, and we developed 4 outcomes from all of those conversations. First Nations across the country said that when you use your culture-based practices and knowledge to facilitate wellness, then what you'll get as a result is spiritual wellness as represented by hope. You'll get emotional wellness that creates belonging, mental wellness that creates meaning, physical wellness that creates purpose. And inside that blue circle, we use blue to make it neutral, because every nation of people will have their own colors that are critically important to them to describe the 4 directions. We wanted to make it neutral, not to create any challenges on diversity. And so First Nations across the country agreed that there are 13 critically important things or indicators or ways to facilitate hope, belonging, meaning, and purpose. So we developed an assessment that is used in treatment services as well as in communities, and I'll talk to you about that at the end of the presentation, that demonstrates how culture makes a difference. The third framework is the First Nations Mental Wellness Continuum Framework, and this framework was released in 2015. Again, from the same process, it's First Nations conversations across the country that built this framework. And because it's First Nations voice, not a top-down where Thunderbird says, this is the way we're going to do things. It was the bottom-up, from grassroots, from community, from regional organizations that said, in order to facilitate mental wellness, We need to bring the conversation of substance use and mental health together, and we need to think about it in a strength-based way. So that's why they talked about wellness. And they said that if we are facilitating wellness, then every investment, everything that we do, from policy to practice to, you know, prevention and health promotion to intervention and specialized treatment, it should all be measured by the extent to which it contributes to hope, belonging, meaning, and purpose. And again, First Nations said culture has to be central, but it also has to be the foundation. And so the color, background color of the mental wellness continuum framework represents that voice. Culture has to be the starting place, it has to be the foundation. And that means including our knowledge keepers, it means including those who hold Indigenous knowledge, it includes our cultural practices and language. That's the starting place. How does culture inform what we do? So when we're talking about a model of care, we are still in a process of decolonization. Many of our communities have not employed culture and Indigenous knowledge to inform our programs and services because our funders have not always appreciated that knowledge as credible evidence. But we're making a difference. And I'm going to tell you a little bit about that. And the difference is, one example I'll talk about is land-based services. You know, when we released the Honoring Our Strengths Renewed framework in 2011, land-based services were barely on the scene. There wasn't investment. There wasn't an appreciation for the importance of the connection to the land. So if you go out on the land and you learn about the trees and the plants and the beings that live there, how does that help you with your addiction? That was the question. So there was not a lot of understanding. And because there wasn't a lot of understanding, there wasn't policy that would facilitate funding land-based services. That's not the case today. So this model is a systems model. And we've been, as I said, working at supporting First Nations in actually implementing this model. It promotes accreditation, which is how we monitor our services to ensure that they are quality services, that they deliver what they intend for substance use and addictions, that the workforce has competencies that they're certified against to ensure they have the ability, they have the knowledge, the skills, and the behavior that ensures that people in their services get the care that they need and that it makes a difference, that it's specific to them. The coordination of systems, moving from one element to the other. So community-based services to residential live-in treatment services are the two components that First Nations are mostly aware of because those have been the two components that First Nations have been funded for. So early intervention, brief intervention, harm reduction or secondary risk reduction are not services that First Nations have had access to because they're not funded always by, there's differences in funding between what the federal government will fund and what provincial governments will fund, or the relationship that First Nations may have with provincial and territorial governments. And so that continuum of care does not currently exist for First Nations. And we're still working at building access to those services. And that's why the model of care for community-based substance use services is so critically important. So First Nations themselves, they developed this model so they have an understanding about these components, but they have not had the resources for those community-based services. So intervention is something that happens outside of the community. You have to go someplace like the residential treatment center or to the city to access harm reduction services, or maybe you're going to get access to brief intervention, through another doorway. And so communities don't always know, if I had resources for community-based services, where would I put those resources? How should I think about the design of those services? So a model of care answers those questions. So the model of care is a companion to the Honoring Our Strengths Renewal Framework. I always refer to it as HOS. But we're living in a time now where we have many different aspects of addictions that are impacting communities. And so we worked with the Canadian Research Initiative on Substance Misuse, funding we received to them to develop some guidelines on opioids and methamphetamines. And those guidelines are meant to help communities understand what are these substances, how do they affect people, and what are the available interventions or approaches that a community can employ to address the impact of opioids and methamphetamine. So we have these documents. We're updating the HOS renewal framework based on what we heard from the conversation on opioids and methamphetamine. And we're strengthening the Honoring Our Strengths renewal framework to speak to the drug crisis, the community-based needs related to substance use. So how does a community respond when they don't have the resource, they don't have the equity, when we compare off-reserve, what's available in the urban environment, and what a community needs to offer its population in order to survive the drug crisis. So that's really what is driving this model of care. And then we got a request from a First Nations Health Authority last year, and they said, can you work with us to develop a model of care for all of the First Nations that are the responsibility of this First Nations Health Authority? And so we did that. And from that place, we got more requests. And we thought, well, let's develop a template that can be used by First Nations on their own or in partnership with Thunderbird in supporting them to develop that. So First Nations communities are not the same across Canada. They all have different size populations. They have different needs related to substance use. They have different strengths related to their culture, their partnerships, the determinants of health. There's different dynamics that will shape and form every community. So there's lots of diversity. So in order to standardize a model of care, we thought in conversation with these communities, we'll take key elements of what they have determined as important to them, excuse me, and we'll develop a template that can facilitate the conversation and help a community to look at their priorities, to understand what resources they might have to responding to substance use. And so, of course, we want to understand that current context. And from that current context, what are the key priorities from that community's perspective? And what's a way of engaging the population in that community to have the conversation about their priorities? And are there specific populations in their community that have greater need than others? So if we think about substance use and addiction and the drug crisis, then what population is most affected by the drug crisis? In other words, what is the age range of the population who we're losing to drug poisoning, to deaths related to overdoses? What age category? Is it men, women, two-spirited, non-gender, fluid genders? Who are the people that are suffering the most related to substance use? Individuals. But then what is the relationship with family and the whole community for these populations? Remember, key principle is that we have to think about not only the individual, but the whole community. And how can the community respond? And then what infrastructure is needed to actually move forward with implementing what they see as necessary to address the issues. And then how are we going to measure, how are we going to evaluate what the model of care assists the community in? So we heard from conversations on a current context is that we have to consider the demographics of the community. Are they rural communities in close proximity to urban environments? Are they rural where it takes hours to get to the local town or the city? Or are they completely remote where you can only access the community by air or by ice roads in the wintertime? The second part, so where are they located and what do they have access to? What are the cultural strengths of the community? Do they still have their language? And they might have their language intact, but maybe they're practicing culture from the way that they live off the land rather than through ceremonial practices. That's okay. It's still culture. It's still a strength of the people. It's necessary to know that. And then what are the best practices for community in terms of how they have responded to the ongoing intergenerational presence of trauma? And how do they ensure culture can still be accessed by the population? And then, of course, conducting literature reviews to balance what the community is saying and using also data to help inform the solutions that the community concludes with. So the current context is also that we have, as I said, this network of live-in treatment centers that vary from 4 weeks treatment for adults to 4 months of treatment, live-in treatment for young people, generally between the ages of 12 and 17, but some programs are further into their 20s that they accept clients. So these two national programs make up about 52 treatment centers across the country. 10 of them are specifically for youth. They together represent about 700 treatment beds and more than 500 prevention-based programs across the country. So not every First Nation, there are more than 600 First Nations in Canada, but we have about 500 community-based prevention programs. And that's because prevention is funded based on the size of the population. And so the size of a population in a community that's very small will not have enough funding to run a program or to employ a person full-time. But there are about 730 community-based workers across the country. So that's the landscape. For First Nations, they know community-based prevention programs and they know residential treatment. They have not had experience to a large degree across the country in operating programs outside of those two aspects of the continuum of care. But that's changing. And it's changing, the change is being driven first by the pandemic. That's our most recent experience. But prior to that, the motivation for change, the requirement for change has been driven by the drug crisis. First Nations people are overrepresented in the deaths, in the people dying from poison drugs, contaminated drugs, from overdose, from not having access to services, to harm reduction services, to safe supplies, sterile equipment for drug use. All of those things make a difference in preserving the right to life. In fact, the UN Commission on Narcotic Drugs and also the World Conversation on the World Drug Problem at the United Nations back in 2016 said that we can't criminalize our way out of this. All of the money that the world has spent on criminalizing people for their health condition has not made a significant difference in reducing the harms related to substances. and that we should focus more on prevention and treatment. So preventing kids from being pulled into the drug crisis, as through human trafficking or through using kids as mules for carrying drugs. Um, Instead, we should focus on health promotion and prevention, using our culture and our knowledge, and do that in schools and all of the places where kids show up every single day, in our communities, in our community programs, in our sports programs. We should be talking about the current landscape of the drug crisis and educating folks to choose life over the pressures that come from all of these other sources. And we should have recovery resources where people live. That means in community. And if we offer services, if we build services, if we ensure equity for services in community, then we are preserving the right to life. And that our approach to treatment is we have to think outside of our historical experience. And our historical experience has focused on alcohol. And that's one of the first reasons that the National Need of Alcohol and Drug Abuse Program was established. It was focused on addressing alcohol. And so First Nations people have a lot of pride in the great successes they have had in changing the presence of alcohol in our communities and for First Nations people. In fact, the First Nations Information Governance Center, through their regional longitudinal health survey, they said in their first report that alcohol use amongst First Nations in Canada was less than the general Canadian public, proving the great success First Nations people had in addressing alcohol. But they approached it from that unresolved trauma lens, which is from the quadrant that deals with our emotional wellness and all of the unresolved memories that we carry from generation to generation. The experience of residential school, the experience of losing our land, the experience of racism, that was all approached from that emotional aspect of the medicine wheel. For the drug crisis, we can't afford to counsel our way out of it. Counseling is not the first line of intervention. And I ask you to think about the worst flu you've ever had, and maybe you had COVID, and that was a horrible experience for you. You were in no shape to talk about the intergenerational trauma that you're carrying. You didn't want to, discuss your history of sexual abuse, while you're trying to recover from pneumonia. It's the pneumonia that needs attention from a physical perspective of your being. And that's the intervention that is needed for addressing opioids and methamphetamine, because those drugs created a physical dependency. And even though you might want to stop, you can't just make a decision and then stop without suffering and without experiencing an intense pain and discomfort by not having those drugs in your system. So we have to understand how the physical body works and approach addressing substance use and the drug crisis from that perspective. And so it's physical life first. Everybody has the right to live life. And we have to understand that the breath that we have that keeps us going every single day, and we don't even think about until maybe we're coughing or we're choking, that is a sacred breath that was given to us by the Creator. And if we think about spirit-centered care, like the Honoring Our Strengths framework talks about, then our approach has to be from a family and community perspective. We all have responsibility to preserve the sacred breath of life. So the priority then is, figuring out a community defined process to engage conversation with the community. Can't develop a framework or a model of care without their involvement. And it has to focus on key issues that we're currently facing: the toxic drug crisis, the unresolved trauma that we have not had community-based resources to address, the state of emergency that many First Nations communities have declared related to all of the harms related to substance use in their community, and then the inequity across the determinants of health. Those have to be central to that conversation so that we can think about who are the populations most affected. If we're talking about prevention, then how do we ensure more prevention health promotion in the community and across the community in all of our programs and services? What's the population? How would we describe those who are most affected? And how are they currently being served? What do we need to change? Then what infrastructure exists in the community? And using those guiding principles to guide how we look at what's the infrastructure, how we design the program, what are the treatment approaches. So it's not throwing the baby out with the bathwater. My message is not do not use cognitive behavioral therapy. That's not what I'm saying. I'm saying that can be beneficial, as the elders said. But we also have to think about what are our cultural practices that attend to the spirit, because that's what's going to make a difference for First Nations in relation to substance use. And then if we're talking about using culture as the foundation, what knowledge and skills does the workforce need to have? Because I'm a social worker and I never learned anything about spirit-centered care when I went to do my bachelor's and my master's degree in social work. So how do we invest in developing the workforce to ensure they have the knowledge and skills to answer the model of care? So the left-hand model or illustration, it talks about the population needs and the services and support components specific to that population across the continuum of care. Now, it says the typical things like community development, brief intervention, and risk assessment, and pre-treatment support, outreach, in case management and residential treatment and culture. But it doesn't indicate how a community would go about structuring that, who has to be involved. And so this model on that has all of the circles and may be difficult to read, what it's talking about is community has to be the hub. The model of care has to build off of community strengths and resources and what communities have decided are specific needs to them, but it brings in other partners. And so instead of sending an individual out of the community to the local town or city to access services, those service providers need to have a partnership with the First Nation to understand their specific culture, understand their specific needs, and figure out how do they move into or support community-based services. Now, I'm talking about this as though it's a brand new idea. Community-based services is not a brand new idea, but it is new for First Nations because we are not funded. First Nations communities are not funded for community-based intervention. And that's exactly what we need in a community-based model of care to address substance use if we are going to survive this drug crisis. It's not okay to say, oh, First Nations people, you're not my problem. You're another jurisdiction. It's okay if you die and you don't have access to services. That is not okay in Canada. We cannot say, First Nations people, you're not my problem. We are the First Nations of this country, and we have an important role to play. We are important all across this country just because we're human beings, because we are First Nations. And so we need access to services. And they might look like those land-based services. It may mean rapid access to addictions medicine. And I want to say a huge thank you to all of those prescribers who are partnering with First Nations communities, supporting their community development so that First Nations have access to the medications that will help them to survive, that will preserve that sacred breath of life. who have access to harm reduction supplies? How do First Nations have access to the free naloxone kits that the provincial government makes available in Ontario if they're in a remote and isolated community? Um, where is the support for wraparound supportive housing? We're already short on housing in First Nations communities, and now we're talking about the housing needs of First Nations people who have a dependency on drugs, not knowing what would happen when they first started taking, or food security. There's a lot of food insecurity amongst people who use drugs. They have a right to food. How do we ensure that? How do we ensure supports for family? We also need that clinical care, as I said, those Western-based models that have proven to work for First Nations. We can't set those aside. We still need those, and counseling services, as well as cultural counseling services and referrals to other kinds of things. When First Nations people have access to those supports to stabilize their life, and they get access to housing, and they get access to food security, or they establish food security and income supports, then after a period of time, they're ready to move on in their life, and that's called recovery. So those resources like training and access to medical care for other issues that they might be facing, or for helping communities as a whole to manage those community crises. So the community has to be the center. It has to be the hub of services. And I see that I'm running out of time here, so I'm just going to move to measurement and evaluation. This national system also has a database called the Addictions Management Information System. And we have lots of data around how well we approach substance use, but also the needs. And then we have a community-based survey that we've implemented on opioids and methamphetamine. And that data tells us a story. And so through that, looking at that data across 3 years, we filtered it and we said we want to only look at the data where there are culture-based practices that have anything to do with land, that are facilitated from the land. And we want to know how well do people entering treatment do by accessing land, receiving culture-based treatment that is connected to land. And we see across time that there are significant increases in the area of emotional wellness and physical wellness, as represented by belonging and purpose, consistent. So that tells us that the instrument actually measures what it was designed to measure, but that land is appropriately attached to relationships in the area of belonging. Also through the pandemic, we made changes to that national information management system so that we could collect data specific to the timeline of the pandemic. And so treatment centers converted their programs to virtual services, but they were still able to facilitate the Native Wellness Assessment. And what they see is, in these bright green bars, is that even by adapting what we're doing from a cultural intervention perspective, it still makes a difference in the virtual environment. And I reference Clay's earlier comments that praying when we're all in different areas and different locations sometimes is a challenge, but we've seen that makes a difference. Praying with people virtually, talking about teachings, helping people to understand the importance of their identity, it facilitates wellness even in a virtual environment. So in conclusion, a community-based model of care has to attend to the whole person, to the individual, family, and community. It has to be informed by trauma, but it focused on healing in culturally safe ways. We can't forget about the determinants of health, because they certainly have an impact. If you're homeless before you go into treatment services and you're homeless after treatment services, the capacity to maintain your wellness and progress in your recovery are limited by that. And that we need collaboration with all levels of government to ensure sustainable resources and ongoing investment to facilitate meaningful change. That's our website. You can go to our website and find any one of those frameworks. Miigwech.
Wow. I didn't want to come in and say we were running out of time because I just wanted to hear everything that you were saying. And I'm just so blown away by this because, those of us who work in community, this is all stuff that we've known and done for many years. And, no one in the system has listened to this until you started saying it. And, you
Thank
bring
you.
that power, you bring that voice, you bring that, authority and that strong voice that we need. So I don't know if you have time for questions, if you want to stay for 5 more minutes, or
Sure.
we want to end it now. It's
I'll leave
kind of
that
up
to
to
you to
you.
decide. Yeah.
I can only stay for 5 minutes because I have to rush off to the
Yep.
Faculty of Law in person.
Okay.
After I let the dogs out. But so let me look into the questions in the Q&A. There's none there. Let me look in the chat.
I didn't see any there
I don't
either.
see any. So I will remind people to fill out the survey of the feedback. I think people are just so overwhelmed, but I think Clay and Sue both have a question or comment. I can tell by looking at them because I know them so well of their body language. So Clayton, I'm sure that you have a question you want to ask.
No, more of a comment that just again, just echo what you were saying. It's amazing. I was just blown away. All the hard work that you're doing and it's just incredible. So, and that's exactly what we're trying to do here at the same time. I think it's so important when we're talking about the cultural and the respect for different ways of approaching the circle. And this is what we're all about here is research is ceremony is research,
Right.
right? And
Yeah.
that's our philosophy here. That's our whole way of approaching it. So, miigwech, and thank you for everything. That's just, yeah, and I just like just
Okay, well, this is a testament because in all the years I've worked with Clayton, I've never heard him speechless. So we got to keep you around, Carol. Usually I'm kind of standing
exactly.
there being like, okay, time to stop talking. We got, but I do see there's some things have popped up in the Q&A, so I'll just read one of them out loud. So are there opportunities for public funding? Has this been sought and any progress in that space? And I think that's the key thing, progress. There was mention of provincial and federal funding,
Yeah,
private
there
and
is
public as
progress in that
well.
area. Like I said, land-based services was not a large conversation in Canada. It was not in government policy that would facilitate funding, but it is now. And, we have more traction on culture. So when I talk about culture and Indigenous knowledge, there's more understanding and there's not as much pushback to say, well, there's no evidence to say that actually works, so we can't fund it. There's more, governments have been more inclined to fund culture-based, Indigenous knowledge-based programming and services. The gap is the inequity between on-reserve programs and off-reserve programs. So the National Native Alcohol and Drug Abuse Program is a nationally funded program by the federal government, but its funding is based on a per capita rate. And off-reserve treatment centers receive about 50% more funding than First Nations treatment centers. And we've demonstrated our quality. We achieve standards of excellence for accreditation. We ensure our staff, our human resources meet core competencies in addictions and substance use, and they're certified against those core competencies. So even though the quality of our programs are high, our funding is 50% less than provincial services. And like I said, those community-based services don't exist because no one has funding for that. So the federal government does not have the obligation for funding prescribers or physicians and nurse practitioners in First Nations communities. Under the Canada Health Act, that's a responsibility of province and territory. But not every province and territory has a relationship with First Nations to facilitate that. That too is starting to change. And like with the creation of First Nations health authorities, provinces, federal government, First Nations governments are sharing space around health. And so we need to keep moving in that direction. And we also need to increase the funding to on-reserve First Nations services, such as treatment centers.
That was wonderful. And I have a question. It might be a little bit loaded, so if you don't want to answer it, that's okay. I'll just say, we don't have time to talk about this right now. But so what do you think about working with, like, as researchers or policy people, which is I think what a lot of the audience is, working with partners like AFN, CAP, Congress of Aboriginal Peoples, the MNC, or these political organizations to try to move, to make those system changes. Because I think as researchers sometimes, or community people, we're kind of wondering, like, should we be working with them? Shouldn't we be working with them? Like, what are the kind of considerations for that?
Well, all layers of government, they need good evidence. And so if the Indigenous research community can benefit decision makers, then of course there should be a partnership. And like the federal government, they've asked me to serve as co-chair on some of their expert task force. There's all kinds of researchers that play a role on those task forces. It's not always service providers, although they are there, as well as people with lived and living experience. So they've expanded their understanding of where evidence comes from. And on those committees that are advising those, I serve federal and provincial committees, they're bringing in researchers and academics, and they're bringing in people with lived experience. They're bringing in service providers. They're paying attention to different populations, and so it's no different for us. The Assembly of First Nations was a partner in developing those frameworks. Um, they supported the development of the Honoring Our Strengths and Renewed Framework to address substance use amongst First Nations. They supported the development of the Indigenous Wellness Framework. They supported the research and development of the First Nations Mental Wellness Continuum Framework. And so they're a necessary partner because they have a specific role, and that role is to elevate the voice of First Nations that align themselves with, I'm talking about the Assembly of First Nations. But it's the same for MNC, Métis National Council, wherever for Indigenous people, First Nations, Inuit, Métis recognize and validate an entity as serving their voice, serving their place and their needs, then those entities are absolutely necessary in the conversations.
I love the way you make everything sound so simple and easy to understand. And that's
Oh,
been a
thank
real
you.
power in your presentation and your work, over the decades you've been doing it. And that's part of why you're so successful, apart from how strong of a spirit and intellect you have. So I think we'll just leave it there, because I could sit here and talk to you for hours. And I'm
Well,
sure
thanks
everyone
again
else
for
is
the
like,
invitation. Thanks
get off
again.
the phone. So,
No, and thank you for all your good work. I appreciate
uh,
your leadership. All of
I'm
you at
fangirling around you. It's
Nest.
hard to be around you for me. I get all flustered and crazy. I don't know what to say. So I'm like, oh my God, there's Carol Hopkins. When I saw you last time somewhere, I'm like, anyways, so I'm going to turn it to Clayton and Sue together to make closing comments and close. So Massey Cho, Massey Miigwech, thank you so much.
Well,
Massey Cho,
Sue?
goodbye, everybody. Thank you so much. It's great to have you. Sue, did you want to say anything?
yeah, I just wanted to say to Carol, I love your presentation. It was just you hit it on the nose with everything, basically. When it comes to our people with the drugs and housing and stuff, that's a major thing anywhere, especially in Toronto. There's a lot that are out in the streets and stuff like that. Like I have a niece who's done like that, and you can only do so much for them and stuff like that. But yeah, I just Chief of Wit for your presentation. I loved it. It was great. Thank you.
Thank you for inviting me, and thank you all for your leadership and your good work.
No.
Miigwech.